Okay, let's jump into this. Just think about it for a minute. How many people do you know, maybe even yourself, who've had like a sprained ankle
Oh,
or pulled a muscle?
oh yeah, happens all the time.
Or, maybe even something more serious like breaking a bone. These kinds of musculoskeletal things are just super common.
It's incredibly common.
And we often think, okay, it's straightforward, just needs time to heal. But actually, sometimes even with those simple injuries, there's surprising stuff going on underneath. Potential risks, complexities.
It's true. The body's response, it involves these really intricate systems. Understanding that is, well, it's key for good assessment and care.
And that's exactly what we're doing today. We've gone through this pretty substantial source guide on musculoskeletal care. It's dense, lots of info. But our goal isn't just to list facts. It's to cut through that, pull out the really crucial bits, the connections maybe you wouldn't expect, and help you get why these details matter, in the real world for
Yeah.
spotting problems, guiding recovery.
Yeah, we're aiming to synthesize it all, highlight those critical links between, say, an injury, how you assess it, and what complications might pop up. Hopefully give you a few aha moments that stick.
I'm actually really interested to dig into this, find those unexpected angles in what seems maybe a bit dry at first glance.
And I'll be focusing on the analysis, sort of connecting the dots, and really emphasizing the clinical significance, why this stuff matters.
Okay, so let's start with the really common stuff. You twist your ankle playing sports, maybe pull something reaching funny. We're talking sprains and strains. What's the quick difference there, the key thing?
Okay, so a strain involves ligaments. Those are the tissues connecting bones together around a joint, so you stretch or tear those.
Right, ligaments, brain, got it, and strain.
Strain is muscle or tendon. So you've overstretched or maybe torn muscle fibers or the tendon that attaches the muscle to the bone.
Muscle tendon, okay. And managing these initially, the classic advice is pretty simple, isn't it? Rice-E.
Absolutely. For these common ones, ROC is, well, it's fundamental. Rest, ice, compression, elevation. It's all about limiting more damage, controlling that swelling and pain.
Simple, effective. But okay, let's ramp it up a bit. What if it's not just a sprain, but an actual fracture, a broken bone? Emergency situation.
Oh.
What's the absolute number one thing to know? What do you not do?
Right. This is crucial. The source material is super clear. Do not try to reduce it. Don't attempt to push the bone back or straighten the limb out yourself.
Okay, definitely don't play hero. So what should you be doing then?
The focus is immobilization. Keep that limb still. Use a splint if you can, even a makeshift one. And hemostasis. Stop any bleeding with pressure.
Secure it, stop the bleeding, wait for help. Makes sense. Now, okay, fast forward. The person's got a cast. There are some really practical things about cast care that are important, right? Like how long does it actually take to dry?
Well, for a traditional plaster one, maybe about 30 minutes to feel dry, but full strength takes longer. More important, though, is elevation. The material really stresses elevating that limb, especially right after it's put on.
Right, elevation.
It helps prevent swelling inside the cast. Swelling can make the cast too tight, compress things underneath, cut off circulation.
Ah, okay. Elevation stops it getting too tight. And how do you know if it is getting too tight?
That's where those 5 Ps come in. We'll definitely get into those. You have to keep checking the limb using that assessment.
Right, the 5 Ps. And what about taking the cast off, that buzzing saw?
Yeah, good point for patient teaching. The cast saw vibrates a lot, but it's designed not to cut skin, assuming, it's used properly. It cuts the hard cast material, not you.
Good to know. Okay, another way to manage bad fractures is traction. What's the basic idea there? Using a pulling force.
Exactly. Traction applies this continuous pull, usually to line up broken bones or stop muscle spasms from pulling them out of place. And the absolute golden rule, non-negotiable, according to the source, never interrupt therapy. That pull has to be constant.
Never interrupt it. Got it. And there are different types, like Buck's traction.
Yeah, Buck's is a type of skin traction. So the pull is applied through straps or boots on the skin indirectly to the bone.
Okay.
With Buck's, you need to make sure the patient stays midline in bed, check for skin breakdown under the straps, and critically, the weights. They have to hang freely, not resting on the bed or floor.
Weights hanging freely seems like a big theme. What about skeletal traction? That sounds more intense. Pins in the bone.
It is more invasive, yeah.
Okay.
Pins, wires, screws go right into the bone. Care there is really meticulous. Pin site care is key.
What about that?
Interestingly, the material says to leave minor crusty drainage alone at the pin sites. It can actually form a natural barrier, but you must check the caps on the pins. If one's missing, especially if you can't find it, call the surgeon right away. It could have gone into the tissue.
Wow.
And yes, just like bucks, those weights for skeletal traction must hang freely too.
So skin or bone traction, consistency, and free weights are key. You mentioned the 5 Ps for casts and traction. Let's really unpack that. What are they and why are they so fundamental for checking on these limbs?
Okay, the 5 Ps are like our rapid neurovascular check. Basically, is blood flow and nerve function okay in that limb? They are. Pain, pallor, pulse, paresthesia, and paralysis.
Pain is first. And you said earlier, it's not just any pain that's a worry.
Exactly. Pain that's off the charts, not controlled by meds. Pain that seems way worse than the injury looks. And especially pain when you passively stretch the muscles in that area. Those are major red flags. Could be compartment syndrome.
Okay, intense pain. What's pallor?
Pallor means color. Is the limb pale, dusky, bluish? That suggests poor blood flow, not enough oxygen getting down there.
Pulse. Pretty straightforward.
They're checking the pulse below the injury, like in the foot for a leg fracture. Tells you if blood is getting through. But here's a key thing. Losing the pulse is often a late sign. If it's gone, things are probably already quite bad.
Paresthesia. That's numbness and tingling.
Yes. That signals nerve irritation or damage, maybe from pressure or lack of oxygen. This can actually be an earlier warning sign than losing the pulse or movement.
And the last one, paralysis.
Inability to move the fingers or toes, for example, like pulselessness. This is usually late and very serious. It means significant nerve or muscle problems.
So those 5 things, pain, pallor, pulse, paresthesia, paralysis, give you this really powerful quick check on the limb's health. It's amazing how basic but critical they are. But things can get way more serious, right? These injuries can trigger other problems.
Absolutely. That's a huge point in material. A fracture isn't just about the bone. It can kick off systemic issues.
Let's talk compartment syndrome first. You mentioned it with the pain P. What's actually happening inside the limb there?
So your muscles are grouped in compartments, wrapped in this tough tissue called fascia. Compartment syndrome is when pressure builds up like crazy inside one of those compartments, usually from bleeding or swelling after an injury.
And that pressure, what does it do?
It squeezes everything, blood vessels, nerves. It cuts off the blood supply and damages nerves. If it's not treated fast, the tissue can die. Irreversible damage.
So the 5 Ps are basically screaming, emergency here. How do they show up?
The pain is the big one. Severe, out of proportion, pain with passive stretch. Paresthesia, the numbness, tingling, is common too. Pallor, paralysis, pulselessness, those are the later really bad signs.
And if you suspect it, what do? There was something counterintuitive.
Yes. Do not elevate the limb high. Normally, elevation helps swelling. But here, it can make it harder for blood to get into the limb against that high pressure.
Wow. Okay, so no elevation. What else?
Get rid of anything tight, cut off bandages, split the cast, call the doctor immediately. Often, they need to do a fasciotomy, surgically cutting open the fascia to relieve the pressure. Urgently.
Fasciotomy. Okay. Elevating is usually good, but potentially really bad here. That's a key insight. What's another serious complication? Fat embolism.
Yes, fat embolism. A big risk, especially with breaks in the big long bones like the femur or the pelvis. Little bits of fat from inside the bone marrow can get into the bloodstream.
And where do they go?
They travel around and can get stuck in tiny blood vessels, often in the lungs, sometimes the brain.
And when does this usually happen after the break?
Pretty quickly, usually. Within, say, 24 to 72 hours.
Now, the signs. The material pointed out something really specific, almost surprising, as a key clue.
This is a really important one to remember. Petechiae. Tiny little red or purple spots on the skin, like pinpoint bruises.
Petechiae? Where do they show up?
Often on the chest, the neck, and in the armpits, the axillae. Seeing that after a long bone fracture is a huge red flag for fat embolism.
Wow, petechiae on the chest from a broken leg. That's exactly the kind of non-obvious link we're talking about. What other signs?
Depends where the fat lodges. Lungs are common, so sudden shortness of breath, fast heart rate, maybe confusion if it affects the brain.
How do you prevent it?
Early stabilization of the fracture is key. Getting that bone fixed quickly reduces the risk.
Okay, fat embolism, serious stuff. Speaking of things getting stuck in blood vessels, what about regular blood clots? DVT?
Deep vein thrombosis, yeah. A blood clot forming in a deep vein, usually the leg. Being immobile after an injury or surgery really bumps up the risk.
What are the signs to watch for?
Usually it's just one leg. Unilateral calf tenderness, warmth, redness, swelling. You can compare calf sizes, measure them.
And if you suspect a DVT?
Elevate the leg, maybe warm compresses, anticoagulants, blood thinners. And crucially, you watch closely for signs of a PE.
Ah, pulmonary embolism. Because that DVT can break loose.
Exactly. A piece breaks off, travels up, and gets lodged in the lungs, blocking blood flow there. That's a PE.
And the signs for PE, are they subtle?
No, usually sudden and dramatic. Sudden severe shortness of breath, chest pain, maybe turning bluish cyanosis, rapid heart rate, blood pressure can drop. It's an emergency.
Definitely sounds like it. What do you do?
Get the head of the bed up, give
Yeah.
oxygen, call for help immediately. That DVT-PE link is potentially lethal, which is why preventing DVTs is so important.
So how do we prevent them? What are the strategies?
Several things. Ankle pumps, dorsiflexion, just moving the feet up and down, using those sequential compression devices, the SCDs that squeeze the legs, giving preventative anticoagulants like heparin or Lovenox, and getting people moving early ambulation as soon as it's safe.
Right, keep the blood moving. Lots of steps involved. Okay, let's pivot slightly. Let's talk about a major risk factor that makes fractures, especially hip fractures, much more likely. Osteoporosis. What is it, simply?
Osteoporosis means bone density is way down. Bones become weak, porous, brittle, much easier to break, sometimes from just a minor fall or bump.
And the risk factors. The source mentions some surprising ones beyond the usual suspects.
Yeah, besides getting older, being postmenopausal, family history, low calcium vit D, it mentioned long-term use of some common meds, like PPIs, those stomach acid reducers, and corticosteroids. Also, heavy alcohol use.
PPIs affecting bones.
Route.
Okay. Prevention. What helps?
Getting enough calcium and vitamin D, definitely. Weight-bearing exercises, key walking, lifting weights, anything that stresses the bones a bit, and avoiding too much alcohol, caffeine, tobacco.
How do they diagnose it, for sure?
The best test is a DEXA scan. Measures bone mineral density accurately. Regular x-rays. They only really show it once you've lost a significant amount, maybe 25–40% of bone mass. DEGIS catches it earlier.
DEXA scan, got it. What about treatments, medications?
Calcitonin is one. Sometimes in a nasal spray, you alternate nostrils. Then there's a big class called biphosphonates, drugs like Fosamax, Actonel, Veniva.
And for those biphosphonates, there were some really, really critical instructions. Safety things.
Oh, yeah, absolutely vital. You have to take them on an empty stomach first thing in the morning, usually, with a full glass of plain water. Not juice, not coffee, just water.
Okay, empty stomach, full glass of water. What else?
And this is the one people might miss. You have to stay upright, sitting or standing for at least 30 minutes after taking it. No lying down.
Why?
To prevent it from irritating or damaging your esophagus, it can cause really bad heartburn or ulcers there if you lie down too soon.
Yeah.
They're often taken just once a week, too.
Yeah.
And you need to report any chest pain right away.
Empty stomach, water, sit up for 30 minutes. That's crucial. Okay, let's connect back to hip fractures, especially after surgery, the posterior approach. Big risk of the new hip popping out, right? Dislocation.
Yes, huge risk. The hip is unstable, especially if you bend it too far forward, more than 90 degrees. Bring your leg across your body, adduction, or turn your toes inward. Internal rotation.
So how do you stop that? There's that pillow.
The abduction pillow, that big wedge they put between your legs.
Right. What's it actually doing?
It keeps the legs spread apart in a neutral position. Specifically stops you from adducting or internally rotating, the movements most likely to cause dislocation after that surgery.
So teaching the patient is key. What do they need to know?
Main things. Keep your knees apart. Always use that pillow between your legs in bed or when resting. Never cross your legs, not even your ankles. Don't bend way forward at the hips. Keep that hip angle less than 90 degrees. It's all about protecting that new joint while it heals.
Makes sense. Protect the position. Okay, a couple more conditions quickly. Phantom limb pain. What is it? Is it real?
Oh, it's absolutely real. It's a type of neuropathic pain. Happens after an amputation. The brain is still getting pain signals as if they're coming from the limb that isn't there anymore.
What's the pain like?
It varies a lot. It can be coldness, heaviness, cramping, or sharp, shooting, burning, even crushing pain. It's complex and requires real treatment.
Sounds incredibly difficult. What about osteomyelitis?
That's a bone infection. Infection right in the bone itself.
How does that even happen?
Few ways. Bacteria can get in through an open wound, like a bad fracture. It can spread from an infection somewhere else in the body through the blood, or it can be a complication of surgery.
Who's most at risk?
People with diabetes, older adults, anyone with a weakened immune system.
And the signs. What would you see?
The area over the bone is usually painful, swollen, red, tender. The pain is often described as constant, maybe pulsating, might have a fever too.
And treatment. Sounds serious.
It is. Usually needs long-term antibiotics, often IV antibiotics for weeks, maybe months. Sometimes surgery is needed to clean out the infected bone.
Wow, long-term IVs. Okay, lastly, let's touch on meds again. Pain relief, muscle spasms. We know the OTCs, but quick safety reminders.
Sure. Acetaminophen, Tylenol, watch the liver. Aspirin, salicylates, anti-inflammatory, anti-clotting, take with food. NSAIDs like ibuprofen, also anti-inflammatory, take with food, watch for stomach bleeding.
Take with food for the anti-inflammatories. Got it. Now, prescription muscle relaxers, baclofen, cyclobenzaprine, what were the big warnings there?
Two main things. Respiratory depression, they can slow your breathing, so you have to monitor that. And lethargy, they make you drowsy.
Yeah.
Definitely no driving or using heavy machinery.
And there was one critical drug interaction warning.
Yes. Hugely important. Do not give muscle relaxers together with opioids. The combination massively increases the risk of severe sedation and stopping breathing. It can be fatal.
Okay, that's a massive safety alert. Don't mix muscle relaxers and opioids. So, bring this all together now. We went from basic sprains to complex fractures, scary complications, chronic issues like osteoporosis, key assessments, medication safety. What are the main threads connecting all this?
I think the biggest takeaway is how interconnected it all is. Fracture isn't just a broken bone in isolation. It can kickstart these dangerous cascades: compartment syndrome, fat embolism, PE from a DVT.
And those 5 Ps are like the vital signs for the limb, the early warning system for those cascades.
Exactly. And you see the direct line from something chronic like osteoporosis, weakening the bones, leading to an acute hip fracture, which then brings its own risks like dislocation and the need for specific precautions like the abduction pillow.
Right. And even the treatments, the casts, the traction, they solve one problem but introduce others, like pressure sores or nerve issues, needing constant checks. Back to the 5 Ps again.
And finally, the medication piece. The very specific way you have to take bisphosphonates, or that critical warning about muscle relaxers and opioids, it just shows that managing the pain and recovery process itself has serious safety layers. It's not just about the bone healing.
It really paints a picture of complexity, doesn't it? How one event, like a fall, can trigger this whole chain reaction involving bone, nerves, blood flow, even systemic responses.
It really highlights the delicate balance in our bodies.
So when you think about all these intricate systems and how one fall, one injury can potentially set off these serious complications we talked about, what does that really tell us about the fragile balance needed for just normal health and movement, and maybe the incredible complexity we rely on every day without even realizing it?
It definitely gives you a much deeper appreciation for that underlying structure, how it all works together, and how much support it needs, especially when something goes wrong. It makes you value just being able to walk around normally.